Without objection, the chair is authorized to declare recess at any time. And before I deliver my opening remarks, I want to make note that today the committee is meeting virtually. And in this virtual format, I want to begin with a couple of reminders to the members and participants about the conduct of this hearing. First, the members should keep their video feed on as long as they are present in the hearing to be counted. And members are responsible for your own microphones. So please keep your microphones muted unless you are speaking. And finally, if members have documents they wish to submit for the record, please email them to the committee clerk, whose email address was circulated prior to the hearing. And thank you all for joining us. So good morning, everyone, and welcome to today's remote hearing on R&D support healthy air travel to support healthy air travel in the COVID-19 era and beyond. I'd like to welcome our witnesses and thank you all for being here. Commercial air travel is an essential part of the fabric of our society and economy. It plays a critical role in business, commerce, education, travel, and tourism. We take for granted that we can now easily travel vast distances by air and reach destinations that were once reserved for imagination. In just over a century, air travel moved from our imagination to a reality that has changed the way we interact with each other and connect with the world. Our dependence on air travel will only continue to grow. In 2018, the International Air Transport Association projected that global air travel will nearly double in 20 years, from 4 billion to more than 7 billion annual passengers. As with many other industries, the COVID-19 pandemic has dramatically impacted commercial air travel. In the US alone, passenger air travel was down an estimated 96% in April 2020 from April 2019, merely a year before. Worldwide, the air travel industry is projected to lose more than $300 billion in gross operating revenues this year. And the ripple effects of this shift extend well beyond the airlines to travel and tourism, business, supply chains, and much more. While Congress has provided financial support to the airline industry through loan guarantees, workforce support, and tax relief in the CARES Act, full recovery also requires ensuring safety and reestablishing public confidence as we continue to face the risk of COVID-19. To that end, airlines are taking concrete and proactive steps to protect crew and passengers through increased cleaning, modified boarding procedures, and requiring the use of masks by passenger and crew. These are positive steps, but are they enough to ensure safety and reestablish trust? Additionally, with each airline determining its own approach, individuals are left on their own about what is safe. That's a confusing place to be. That's why today's discussion is so important. It's about understanding what we know, what we don't know, and what we need to know to reduce confusion and provide clear, science-based guidance on ensuring the safety of passengers and crew during this and any future pandemic. Because of the silent threat of asymptomatic or pre-symptomatic individuals remains, federal public health agencies such as the CDC provide guidance and recommendations about precautions and actions to reduce the spread of COVID-19. However, agency roles and responsibilities for determining the risk of virus transmission on aircraft and issuing guidance about specific mitigation measures are unclear. The FAA has conducted research on cabin airflow and aircraft environmental control systems in the cabin. What does that research tell us about mitigating any risk of COVID transmission? As a lifelong Girl Scout, I know the importance of being prepared. The threat of COVID-19 demands a national response. That's why we also need to examine the status of planning for the federal government, for the airlines, and for the traveling public, so that we and the industry aren't caught off guard with the threat of any future pandemics. Further, we need to examine our aeronautics and aviation R&D plans, the extent to which they include relevant research priorities and unique experiences such as healthcare specialists and scientists to deal with the mitigating the risk of novel viruses and how R&D can inform our national plans. In June 16, 2020, article, the president of the National Academy of Sciences wrote about the coronavirus pandemic. She noted the need for actionable science to inform rapid decision-making, strategic science to inform long-term planning, and irreplaceable science to understand what works. Today's conversation will consider what research has been done, what research needs to be done, and what further actions need to be taken to understand and mitigate the risks of virus transmission through air travel. I can't think of a better way to frame our discussion on R&D to help ensure the resiliency of our air travel system during the COVID-19 era and beyond. Thank you. The chair now recognizes Ranking Member Mr. Babin for an opening statement. Mr. Babin.
Thank you, Madam Chair. I appreciate you, and glad to be with you virtually this morning, or this afternoon, I guess now. The COVID-19 pandemic has touched virtually every aspect of our lives. Families are self-isolating and limiting in-person contact with friends and family. Many workplaces have fundamentally restructured in response to this virus. Our economy and employment levels are challenged as we attempt to protect our public health. While industries like restaurants and entertainment were asked to sacrifice profits and solvency for the greater good, other sectors like healthcare and grocers were asked to accept greater risks. The aerospace industry was asked to span these two different paradigms. On the one hand, air travel was significantly curtailed in order to prevent the spread of the disease. On the other hand, transportation, including air travel, is considered an essential function to our society. This places passengers, airlines, and the country in a precarious position of continuing operations in the face of not only health risks, but also risks to the overall viability of the companies who are operating at a fraction of their normal operating capacity. According to recent press reports, airlines are operating at between 15 and 17% capacity compared to last year. At the same time, private jet flights have surged 70%. But this doesn't do anything to help most Americans. Polling done recently by the International Air Transportation Association indicated that only 45% of the population was willing to fly within 1 or 2 months of restrictions being lifted. This does not bode well for an industry that our nation depends upon so heavily. For this reason, it is crucial to understand the health risks posed by airline travel as accurately as possible. Research into how the virus propagates in an aircraft cabin via airborne or surface transmission is the start. Characterizing that environment will then allow airlines, aircraft manufacturers, airports, government agencies, and the public to develop technologies and processes to mitigate those risks. HEPA filters, ultraviolet lights, antimicrobial surface coating and treatments, increased cleaning protocols, passenger screenings, masks, social distancing, and limited movement in the cabin for restroom access and service carts are all options that are being considered. But all of these options are traded against other considerations such as power, weight, maintenance, cabin pressure, comfort, certification, and not least cost. They must also demonstrate efficacy. At the end of the day, the best way to stay safe is to stay home. Any option to fly comes with some element of risk. One could make the argument that the risk of driving to and from the airport, walking through the airport, traveling on buses, tram cars, and so on are far riskier than the actual flight. This may not be true, depending on whether you have a pre-existing condition or being a member of a vulnerable population. Still, it does illustrate that the aircraft is just one of the elements that we have to address. It is the responsibility of our agencies, our legislature, our industry, and our public to find the right balance of risk. That balance may change as time goes by. Strict controls put in place initially to flatten the curve may not be appropriate in the long term. Conversely, controls may need to be reinstated over time if new information is presented. Science will characterize and inform these risks and decisions. And while other factors will undoubtedly play a role in final decisions, understanding the air travel environment is the very first step. This will require an assessment of a variety of disciplines, such as computational fluid dynamics, statistics and modeling, epidemiology, sociology and psychology, chemistry, biology, and many more. This is certainly not an easy task, but it is not unachievable. It is often said that these are unprecedented times, but we have faced similar health challenges before. I'm very confident that we can come through this stronger and more resilient than ever. The aerospace industry and our scientific, technical, and healthcare systems are absolutely second to none. I look forward to hearing from our witnesses today, and I yield back, but I would also ask for unanimous consent, Madam Chair, that a letter from the Airlines for America be added to the record. I yield back.
Without objection, it will be added to the record. Thank you. Thank you, Mr. Babin. The chair now recognizes the chairwoman of the full committee, Ms. Johnson, for an opening statement.
I want to express my appreciation to Chairwoman Horn for holding this hearing, and really make a special thank you for the witnesses for appearing before the subcommittee today. The aviation system is both an important contributor to the U.S. economy and an important factor in the national and global response to communicable disease outbreak. As the threat of COVID-19 continues, it is critical for the health and safety of flight crews, airport employees, and the flying public that science-based policies, practices, and regulations are put in place to reduce the risk of further spread of the virus. Research and development must be part of that solution. Congress has been attentive to public health concerns on aircraft, paying particular attention to the issue of cabin air quality. While researchers have learned about the airplane cabin air circulation and the spread of communicable disease in aircraft, many questions remain. Today's hearing will inform us on the role of R&D in understanding and mitigating the risk of virus transmission through air travel. I also look forward to hearing from our witnesses about how the research is being translated to operational solutions because the airlines, crew, and the flying public really need clear information. The coronavirus is a national and global crisis. Yet, despite international obligations and recommendations from GAO, we continue to lack a national preparedness plan to address the threat of communicable disease transmission through travel. That is troubling, given the devastating toll that the coronavirus has taken on airlines and so many other industries. We need to be prepared to avoid repeating the same mistakes with our future pandemics. I continue to be proud of how the research community and our frontline workers, like those in the aviation community, continue to rise to the ongoing challenge of COVID-19. I look forward to the hearing from our witnesses about how R&D can be part of the solution to healthy air travel during this COVID-19 and into the future. I thank you and yield back.
Thank you, Chairwoman Johnson. The chair now recognizes Ranking Member Lucas of the full committee for an opening statement. Mr. Lucas.
Thank you, Madam Chair, and Ranking Member of the subcommittee and Chairwoman Eddie Bernice Johnson. I can think of no more timely or important hearing than the topics and the subject matter we're covering today, examining the status of R&D as it relates to supporting healthy air travel. As we heard in a hearing earlier this year, in addition to COVID-19, there are potentially 1 million plus pathogens that exist in the wild. So the efforts that we apply to address and deal with the struggles we have right now, whether it's COVID-19 or other things, are more important to the future of air travel than I think we could even possibly imagine. Whether it is the health of each of us individually, our families, our country, or as COVID-19's demonstrated the world, the issues discussed today have to be addressed in a thoughtful manner that will help move everything forward. We didn't just have trouble starting with this plague, but it is a reflection of struggles we've had for decades. I very much appreciate the chair and the ranking member for holding this hearing. I look forward to the witnesses' comments. Let's work together to make sure the lives of our constituents are safer and more productive as a result of this. Yield back, Madam Chair.
Thank you, Mr. Lucas. And thank you again to the witnesses. At this point, if there are members who wish to submit additional opening statements, your statements will be added to the record at this point. At this time, I'd like to introduce our witnesses for this important hearing today. Our first witness is Ms. Heather Krause, Director of the Government Accountability Office of Physical Infrastructure Team. The Physical Infrastructure Team assists Congress and federal agencies to address challenges within the U.S. infrastructure, including transportation systems. Since joining GAO in 2003, Ms. Krause has been an expert on the safety and operations of the national airspace system. Ms. Krause received a Bachelor of Arts degree in Political Science from the University of Minnesota Duluth and a master's degree in Public Policy from the University of Minnesota. Welcome, Ms. Krause. Our second witness today is Dr. Byron Jones. At this time, I would like to recognize Congressman Marshall for an introduction of Dr. Jones. Mr. Marshall, you are recognized. Thank you.
All righty. Good morning, Chairwoman Horn and my good friend, Ranking Member Babin. Hopefully you've got a good connection with me. Running around the state of Kansas right now, but I did not want to miss a chance to introduce a fellow Wildcat from the K-State University. Dr. Byron Jones is the director of the National Gas Machinery Laboratory at the Kansas State University, located in beautiful Manhattan, Kansas. He's a longstanding member of K-State's faculty. He served as the Associate Dean for Research at K-State's College of Engineering. By the way, I might add one of the top engineering programs in the country, and served as the head of mechanical and nuclear engineering and as director of the Institute for Environmental Research. His current research areas include aircraft cabin air quality, aircraft environmental control systems, turbo machinery, and aircraft bleed air contamination. Wow. He serves as technical director of the FAA Air Transportation Center of Excellence for Airliner Cabin Environment Research, and has chaired the development of the original ACRA Standard 161, Air Quality in Commercial Aircraft. He has a bachelor's degree, of course, from Kansas State University. Somehow we let him slip down to Oklahoma State University for his MS and PhD from Oklahoma State University, and all in mechanical engineering. He's a licensed professional engineer, of course, and a licensed commercial pilot. Wow. So that brings some substance to the discussion today. He brings a wealth of knowledge on this topic. And again, welcome to Dr. Byron Jones from Kansas State University, the home of the Fighting Wildcats.
Thank you, Mr. Marshall. and of course, I would be remiss if Ranking Member Lucas and I always have to celebrate all of the amazing Oklahomans that we have. And spending time at OSU absolutely is included in that. I'd venture to guess the Ranking Member agrees with me there. So our third witness today is Dr. Vicki Hertzberg, professor of the Nell Hodgson Woodruff School of Nursing and director at the Center for Nursing Data Science at both at Emory University. Professor Hertzberg is an internationally recognized expert on big data and its impact on healthcare. She has led research efforts in social contact and disease transmission in densely populated indoor spaces, including emergency rooms and aircraft cabins. Professor Hertzberg received a Bachelor of Science degree in Mathematics and Statistics and a doctoral degree in Biomathematics, Health Statistics track from Miami University in Ohio. Welcome, Dr. Hertzberg. As our witnesses, each of you should know that you will each have 5 minutes for your spoken testimony. Your written testimony will be included for the record in the hearing. When you've completed your spoken testimony, we will begin with questions, and each member will have 5 minutes to question the panel, We have a timer here that you should be able to see on your screen, and I will notify you as time is up. We will begin today with Ms. Krause. Ms. Krause, you're recognized.
Thank you. Chairwoman Horn, Chairwoman Johnson, Ranking Member Babin, and Ranking Member Lucas, and members of the subcommittee. Thank you for the opportunity to discuss our work on reducing the risk of transmitting communicable disease through the aviation sector. Air travel, more than any other mode of transportation, creates the potential for infected persons to move quickly from one part of the world to another. Air travel greatly aided and accelerated the global transmission of COVID-19, which is having profound effects around the world. In light of the resulting pandemic and warnings about the risk of air travel, as noted earlier, U.S. passenger airline traffic fell dramatically, dropping 96% in April 2020 as compared to a year ago. COVID-19 is only the latest communicable disease to raise concerns about the spread of contagion through air travel. Since 2002, there have been 6 major public health threats with global ramifications, including SARS in 2003 and the Ebola virus in 2014. Ensuring that the United States is prepared to respond to disease threats from air travel and conducting the necessary research to reduce the risks of a contagion are 2 vital responsibilities of the federal government. My testimony today focuses on 1, the U.S. aviation system's preparedness to respond to communicable disease threats, and 2, the extent to which disease transmission on aircraft and at airports has been a focus of FAA research. Starting with our work on preparedness, the U.S. still lacks a comprehensive national aviation preparedness plan to limit the spread of communicable diseases through air travel. In December 2015, during the Ebola pandemic, we recommended that DOT work with relevant stakeholders such as the Departments of Health and Human Services and Homeland Security to develop a national aviation preparedness plan for communicable disease outbreaks. We concluded that the absence of a national plan undermined the ability of public health and air transportation sectors to coordinate on a response or to provide consistent guidance to airlines and airports. More than 4 years later, DOT is confronting an even more widespread public health crisis with COVID-19 without having taken steps to implement our recommendation. DOT and HHS officials agree that a national aviation preparedness plan could add value. However, DOT maintains that HHS and DHS have both the legal authority and expertise for public health and emergency response, respectively, and that these agencies should leave any efforts to address planning for communicable disease outbreaks, including for transportation. We continue to believe that DOT would be in the best position to lead this effort because DOT and FAA have stronger and deeper ties to and oversight responsibility for the relevant stakeholders that would be most involved in such a broad effort, namely airlines, airports, and other aviation stakeholders. A national aviation preparedness plan could not only provide a way for the public health and aviation sectors to coordinate and more effectively prevent and control a threat, it could also help minimize unnecessary disruptions to the national aviation system, which to date have been significant. In addition, Annex 9 to an international aviation treaty, to which the United States is a signatory, contains a standard that obligates member states to establish such a plan. Now turning to FAA's research and development. FAA has sponsored limited federal research into disease transmission onboard aircraft and in airports. Instead, FAA's research has focused on areas like reducing accidents, improving airport operations and airspace management, and developing new technologies. Such research is consistent with DOT's strategic goals related to safety, infrastructure, and innovation. Even so, FAA has funded some programs relevant to mitigating communicable disease transmission at airports and on aircraft. For example, in 2018, the Airports Cooperative Research Program, or ACRP, which is funded by FAA's Airport Improvement Program, held a workshop on airports' roles in reducing the transmission of communicable diseases. ACRP has issued several reports, including guidance to airports and airlines on infectious disease, mitigation on board aircraft, and for ways to reduce the spread of communicable disease in airports. The Centers for Disease Control within HHS, which is responsible for the nation's public health, also sponsors health-related research involving air transportation. Such research, along with developing and maintaining a national aviation preparedness plan, is critical to ensuring the U.S. is sufficiently prepared to respond to any future communicable disease threat. This concludes my statement. I look forward to answering your questions.
Thank you, Ms. Krause. The chair now recognizes, excuse me, Professor Jones, Dr. Jones, you're recognized.
Good morning, Chairman Johnson, Chairwoman Johnson, Chairwoman Horn, committee members, guests. I am pleased to be able to offer my comments to this committee today. I am a mechanical engineer and do not claim to be a disease transmission expert. However, I have worked extensively with the aircraft environmental control systems, and I believe I understand how they function, how virus-containing droplets are carried by the air within the cabin, and how ventilation systems flush these droplets from the cabin. Sponsors of our research on these topics have included the FAA, CDC, NIOSH, and Boeing. Aircraft and air travel play two distinct roles with regard to disease spread during a pandemic. First, there is the transport of infected people throughout the world, which allows disease to spread across large distances. Second, there is transmission of disease between people within the aircraft. I will be addressing only the latter role, transmission within the aircraft cabin. If I can get my thing to scroll up here. With regard to air travel, I believe the most critical research need in the near term is collection of the data and development of the tools needed to be able to quantitatively assess the risk of COVID-19 transmission on aircraft, and to be able to quantitatively assess the effect of various mitigation measures on that risk. The key word here is quantitative. Expert opinions are plentiful, but reliable data are scarce. The air transportation industry and the flying public need sound quantitative information about risk and the impact of mitigations to be able to devise and deploy the appropriate mitigation strategies and to make informed decisions about air travel. It is unrealistic to expect the risk of COVID-19 transmission in aircraft to be zero in the near future. However, it is realistic to expect that appropriate mitigation measures can be taken so as to ensure the risks are comparable to or lower than exposure risk we face in everyday life. Unfortunately, we simply do not have the data nor the knowledge to confidently make that judgment today. We need these answers today, not in 2 years, not even in 6 months, because we are not talking about a traditional research effort, but rather an immediate focused effort. The scientific community is slowly learning about how COVID-19 is transmitted. However, when all is said and done, there's a lot more that we do not know than we do know. It is believed that a primary means of transmission is via respiratory droplets that are expelled when an infected person coughs, sneezes, talks, or even breathes. These droplets are then inhaled or otherwise transferred to the respiratory system of an uninfected person. The largest droplets do not travel far from the source. However, all but the largest droplets can become partially or fully suspended in the air and can be carried much further by air currents. The smaller ones can stay suspended more or less indefinitely and will stay in the cabin air until they are flushed out by the ventilation air or contact the surface. High-risk environments are those environments with high occupant density, extended exposure time, and poor ventilation. In this respect, aircraft cabins are both good and bad. Aircraft cabins are well ventilated and with a combination of outside air and HEPA-filtered recirculated air. One can be confident the air supplied to the cabin is virus-free. Additionally, the amount of air supplied relative to the volume of the cabin is very high. This high ventilation rate results in an exponential decrease in droplet concentration with distance from the source as the ventilation air flushes the droplets from the cabin as they spread. This exponential decrease has been well characterized through FAA and CDC NIOSH funded research. Some small fraction of the smaller droplets will still be carried a number of seats from the source. The exposure risk presented by these droplets is not known. The ventilation is good on aircraft, but that is not the whole story. The occupancy density is higher than just about any other space we routinely occupy, and that occupancy can extend for several hours or more. Operating aircraft while maintaining 6 feet personal distancing is not economically feasible. Any realistic scenario for air travel in the COVID-19 environment will require other mitigation measures. We understand qualitatively how these mitigations work. However, as stated previously, we do not have the information needed to quantitatively assess the risk of transmission in aircraft and to assess the impact of mitigations on that risk. Ultimately, we need this information to be able to confidently say that air travel poses no greater risk of infection than other aspects of our daily life. I thank you for your attention, and I thank Congressman Marshall for that wonderful introduction.
Thank you very much, Dr. Jones. Dr. Hertzberg.
Ladies and gentlemen, of the committee. Good afternoon. First, a disclaimer: the contents of my testimony represent my opinion and are not the official opinion of the Emory University. Second, I'm Vicki Hertzberg. I earned a PhD in biomathematics from the University of Washington in Seattle, Washington in 1980. I was on the faculty at the University of Cincinnati from then until 1995, and I have been on the faculty of Emory University since 1995. I'm professor and I direct the Center for Data Science in the Nell Hodgson Woodruff School of Nursing of Emory University. Next, I review how I develop particular expertise that qualifies me to testify before you today. After the SARS pandemic in 2002 to 2004, many organizations became concerned about how a novel infectious agent might spread in their environments. There were 2 papers published in the medical literature documenting such spread for SARS, or severe acute respiratory syndrome. One publication described how SARS spread in an emergency department, or an ED. This particular publication led to my collaboration with Dr. Doug Lowry North, an emergency medicine physician. We studied movements of patients and staff in the ED at Emory University Hospital Midtown to determine how frequently and for how long patients and staff came into contact with one another, that being within 3 feet or a meter, in order to understand better how an infectious disease could spread in an ED. Another publication documented SARS transmission on a 3-hour flight from Hong Kong to Beijing. Thus, airplane cabin environments were of concern. Dr. Sharon Norris, the chief physician of the Boeing company at the time, was interested in supporting studies of how a novel infectious agent transmitted by large respiratory droplets might spread among passengers and flight attendants, or what I call the crew on an airplane. She approached my colleague at Georgia Institute of Technology, Professor Howard Weiss, an applied mathematician and an expert in modeling infectious disease outbreaks, who was also aware of our work in the ED. Professor Weiss and I were funded by the Boeing company to determine how a novel infectious disease might spread on an airplane, which we have since called the Fly Healthy study. We quantified behavior and movements by passengers and crew during 10 flights across the country so that we could determine which pairs of individuals were coming into close contact as to enable infection transmission. A second goal was to document what infectious agents were present on airplanes. There were 3 major findings from our study. First, based on our simulations of movement, 1 to 2 passengers or crew member will become infected as a result of contact with an infectious individual on a cross-country flight at the probability of infection that we tested. 2, tests for respiratory viruses were negative for all air samples and all 18 respiratory viruses that were tested. 3, microbial communities present on airplanes are highly variable from flight to flight, with the vast majority of airplane-associated microbes being human commensals or otherwise non-pathogenic entities. Our findings set a baseline for non-crisis level airplane cabin conditions. What are the implications of our findings for air travel in this pandemic? Our results state that if the SARS-CoV-2 virus is as contagious as the novel agent with the transmission rate used in our simulations, one can expect 1 to 2 passengers or crew to become infected on a full flight of similar duration. The implications of this finding is significant. Unless airlines are willing to mandate that passengers and crew show up at least 4 hours in advance of a flight for nasopharyngeal swabbing of all passengers and crew, followed by PCR testing for presence of the virus, and to prevent anybody with a positive test from boarding, and if flights continue to be at or near capacity, there is no way to absolutely guarantee that SARS-CoV-2 virus will not be transmitted during flight. What are the knowledge gaps? What are the unknowns regarding safety of air travel in light of transmission of a novel infectious agent? First, I am not aware of good data that would allow us to determine an infectious rate to use in simulations. 2, the inverse problem needs to be solved. That is, given a passenger who subsequently develops disease, where was the infectious person likely seated? 3, our results are only applicable to large respiratory droplet transmission. We do not know about transmission from aerosol, that is the smaller droplets that are generated, or fomites, that is the physical objects that facilitate infection transfer between people. 4th, our results are only applicable to time in flight between 10,000 feet on ascent to 10,000 feet on descent. There are other places along the way to traveling by air in which infection can be transmitted, and we know little about those places. These include transportation to and from the airport, areas traversed from check-in to the gate, passenger mingling in the gatehouse area, as well as at baggage claim. 5th, we do not know anything about passenger behaviors and movements on double-aisle planes, long-haul flights, or flights outside the United States. This concludes my remarks. Thank you for the opportunity to testify.
Thank you, Dr. Hertzberg. At this point, we will begin with our first round of questions, and the chair recognizes herself for 5 minutes. Again, thank you to our witnesses for your testimony and to all of our members for participating. So we can tell this is a critically important and timely issue that we are addressing here. And it's clear that while some research has been done on communicable disease and transmission in aircraft, we have work to do, and it hasn't risen to the priority that we need to have progress to a national plan. So I'd like to begin with Ms. Krause. Clearly, as you mentioned, this is not the first epidemic that our U.S. air transportation system has had to face. And the question becomes why we find ourselves ill prepared in terms of a national plan. So a couple of questions for you. First, how can we improve the resiliency of our air systems, air travel systems in response to such outbreak? And then second, can you speak to the prioritization of and the development of a national plan, how we can expedite that, especially given the circumstances we find ourselves in?
Absolutely. I think in a way, implementing our recommendation for DOT to develop a national aviation preparedness plan is the way that we can build our resilience for future communicable diseases. What that plan does is offer a scalable and adaptable framework for individual airports and airlines to align their efforts with and really bring some harmonization in a national approach to responding to future pandemics. So I think seeing our recommendation of DOT coordinating with HHS and DHS and other stakeholders is key to ensuring that we're prepared going forward. On the question of sort of the second part was the priority of getting this done. I mean, I think this is important in the sense that what we're seeing is when we did our work back in 2015, you had 14 airports and 3 airlines with a number of different individual plans. And they had some good components, but given that it's fragmented, again, that sort of puts an emphasis on why it's important to develop a national aviation preparedness plan.
Thank you, Ms. Krause. And it's clear that research and development is central to this. So I'd like to turn to Drs. Jones and Hertzberg for the next question. You both noted there are unanswered questions about research and the implication of COVID-19 and other communicable diseases for air travel. And there's discussed both publicly and privately funded research. So given the urgency, Dr. Jones, that you expressed in your testimony of prioritizing this research, I'd like for you to speak to, from your experience, your sense of who should be in charge of coordinating this research and where the federal government role might be, how that might interact with private research. And then the same question to you, Dr. Hertzberg.
Okay, this is Byron Jones. I'm not sure I'm the one to make the decision whether the government or the private or who should fund the research or be in charge of the research. I mean, it benefits the flying public as well as the private industry. So I would hope to see some kind of a joint effort and generally the FAA has been the one who's taken the lead with anything aviation. But I mean, this is really outside my role as a researcher. In terms of the need, I think that in the aircraft, we're going to have some kind of mitigation. We can't sit here 6 feet apart, and we don't even know if that's far enough. So we really need to be looking at how effective, face masks, for example, does allow us to set 3 feet apart, 2 feet apart, 1 feet apart. We just don't know that. And that's the kind of information we need.
Thank you very much, Dr. Jones. Dr. Hertzberg?
You ask about who should be in charge and the funding, et cetera. Having thought about this for a long time, I do think that it needs to be a true partnership with the public health agencies as well as the DOT agencies that understand how airplanes work. We could not have done the work that we did without significant input from Boeing engineers, for instance. And we believe that that is really the ultimate collaborative model to engage in. We also had significant input from Delta Airlines, from Homeland Security, et cetera. As for funding, there's been talk over the years of getting this funded in the private sector that I believe has never taken off for reasons I don't want to get into right now. I could speculate, but that does nobody any good. But in public health, it's always difficult to fund something that you've prevented. And so that's really hard to fund something here to prevent this disease from happening on airplanes.
Thank you very much, Dr. Hertzberg. Thank you to our witnesses. The chair, my time is expired. I now recognize Mr. Babin for 5 minutes.
Thank you, Madam Chair. Very, very interesting. And I appreciate all the witnesses. I would like to ask first to anyone who could answer this, how does airline travel compare to other modes of public transportation from a disease transmission standpoint? Some of these questions I know have already been hit on, but is it riskier than trains, ships, buses, or how does that healthcare risk compare to overall safety, including accidents of each mode of transportation? Can any of you all answer that, or want to? I know it's quite an involved answer, but just do the best you can.
Can I take a stab at it first?
Sure. Yes, ma'am. Thank you.
I don't think that we understand as much as we have actually come to understand about airplanes in the similar way about things like trains and buses and subways and boats. So we don't know, we don't understand how people move about on them necessarily, et cetera. I think that there have been a lot of publications over the years about disease transmission on airplanes. SARS was not the first, and it won't be the last. I believe there's actually papers being considered right now about COVID-19 being transmitted on airplanes. So, but you don't quite see the same level of interest in, oh, I got it on a subway or I got it on a bus. That doesn't mean that it shouldn't happen. I will say that in assessing the bacteria and viruses that were present on an airplane, that we looked very much like, we were very comparable to places that people spend a lot of time in. So for instance, office buildings, schools, we actually looked very closely at something called the Boston Subway Study, and we compare very comparable to that in terms of what is present.
Okay, thank you. Anybody else want to take a stab at that?
Yeah, this is Byron Jones. I'll take a stab at it as well.
Yes, sir.
The one big difference between airplanes and other modes of transportation is that airplanes tend to be the same from one airplane to the next to the next. There's not a lot of difference in the environmental control systems in an airplane, and not a lot of difference in the seating density. You go to other transportation modes, trains can be anywhere from a crowded subway where everybody's crammed in there to a rail car that's half full. And so it's very hard to generalize the comparison between aircraft and other modes of transportation because there's a lot of dissimilarities. But I guess the main thing is if you work with an aircraft, you know what you're working with, you know what the situation is, and in a other transportation vehicles, it could be anywhere all over the map. You just don't know. But given this, if you have the same occupancy density, you have the same ventilation rate, you would expect similar results. And the other factor would be, the duration of the exposure. It's one thing to be on a subway for 5 minutes. There's another thing to be in an aircraft for 3 hours next to somebody.
Right. Okay, thank you. I've got another question I want to try to sneak in first, Dr. Krause. And this is something that people have been thinking about. The seat size and proximity are ways that airlines manage costs. Everyone understands that. If airlines reverse the recent trend of smaller seats that are closer together, should we expect higher prices? When they have us spaced out on those airplanes, they're about 2/3 full, and that's the max. That's something to think about because these airlines have to make a profit. So I'll start with you, Dr. Krause, if you don't mind, or Ms. Krause. I'm sorry.
No worries. Thank you. No, I mean, I think that there's certainly, airlines generate profits and revenues by having people in seats. So that certainly is a factor that comes into play in terms of reducing the number of seats that might be filled or adding more seats and not filling them. So that's certainly a factor that plays in.
Okay, thank you. I've got about 20 seconds left. If somebody else wants to take a stab at that. Okay, well, with that, Madam Chair, I'll yield back. Thank you so much.
Thank you, Mr. Babin. The chair recognizes Chairwoman Johnson for 5 minutes of questions.
Because, first of all, I don't know who is leading the effort to determine how the spacing and what have you should be on our airlines. Of course, that's where many of us in Congress have very personal questions because that is the method of which we travel to get back and forth to work. So who right now is in charge of working with the airlines to determine what is safe and not safe?
I can jump in there, Chairwoman Johnson. This is Heather. I would offer that DOT and FAA generally defer to the CDC when it comes to passenger safety and crew safety. The airlines have taken a number of steps. I know that was mentioned earlier in terms of aligning some of their practices with the CDC guidance and have talked about upping enforcement of some of those provisions like the use of masks on airlines. But I think we would sort of offer that if passengers start to find that their experiences are inconsistent or confusing, that may impact their confidence in the system. And so that may lead to the administration and Congress having to determine whether further action might be needed. I know the administrator was at a hearing last week and spoke about some of the efforts that they're getting underway to come up with more specific recommendations and guidelines. So that effort also is being done. But again, I would sort of say as things start to play out, it will be up to the administration and Congress to determine whether further action or clarification of those roles and responsibilities is needed.
Thank you. Now, Dr. Jones and Dr. Hertzberg, what, in your opinion, are the primary research gaps regarding the risk of communicable disease transmission in airline cabins and that environment of air traffic overall?
This is Byron Jones. I'll take a shot at that first. I think the biggest thing I see in working with people in the airline and the air travel industry is we just don't know the effect we have on that transmission when we take a given mitigation. So if, for example, we put a barrier between the seats, we don't have the information. Does that reduce the risk by 5% or 95%? We just don't know that. Likewise, if we require everybody to wear a mask, does that reduce it by 10% or 99%? We just don't know those. It's very difficult to get those data, and it's not an easy thing to do. We know how once it becomes airborne, how it moves around the cabin, but there's just a lot that goes on in that very near environment, close to the person, that interaction. We just don't know how that goes on, and that's where we expect most of the disease transmission to occur.
Thank you, Dr. Hertzberg.
I would also say that we don't know what role the physical objects play for transfer. So I cough into my hands. I get up. I walk to the back to the lavatory, and on the way, I'm gripping the seat backs to keep my balance. And on the way back to my seat, I do the same thing. And then you get up 30 minutes later. You do the same thing on the way back to the back lab. And you come into contact with germs that I've transferred to those seat backs. And then you touch your face. Okay. And we don't really understand what the role of that kind of transmission could be in this disease. We don't understand too much about whether it's aerosols or large droplets. So there's just a lot that we don't know that's somewhat disease specific as well.
Thank you very much. I think my time's expired. I yield back.
Thank you, Chairwoman Johnson. Mr. Lucas, you're recognized. Mr. Lucas, I think you may be muted.
Would be correct as always, Madam Chair. Thank
There you
for
are.
helping me. Let's touch for a moment back on that size and seat proximity issue. As the full chairwoman noted, it's an issue very important to members who travel a lot. When I first came to Congress, I was 6'4.5". Now, time and Congress has ground a half inch off of me, but I'm still 6'4" in those seats. And it's still a matter of togetherness, even before the public health and safety issues. But isn't this an example that if we do the research, we make determinations about spacing, setting comfort aside, health issues, is this a situation where industry will expect Congress to set standards so that they will be implemented? Because after all, it is a matter of cost control, seat spacing and proximity now. And the farther we're apart, if we determine that's important, and I question the whole panel about this, won't that add to cost, even though it very well may add to the quality of safety and certainly the quality of my needs?
This is Byron Jones, I'll jump in. Obviously, if you reduce the seating density, you increase the cost. There's no getting around that. That's why it costs more to fly in first class. For those who get that opportunity. Most of us don't. And I think the thing to realize is that it will reduce the probability of exposure if you reduce the seating density, but to reduce it down to a very low level, you would have to make the seating density so low that it would be impractical to operate an aircraft in that mode economically. Now, when I say, let me back up. That's assuming we took no mitigations, nobody wearing a mask, nobody's doing anything else at all. You're just in there going about your normal business. So that's why I keep saying and emphasizing the fact that you've got to have mitigations in there to keep that spread from seat to seat, from person to person.
Absolutely. And being of the competitive industry it is, whatever that combination of mitigations are, if it increased the cost of doing business in a competitive industry, and airline travel is incredibly competitive, it'll have to be a standard implemented from the federal level so that everyone will respond the same. Along that line, and I again ask everyone on the panel, and you've been really impressive with your responses and insights, how much money as in the industry as a whole are they spending on doing this basic research? Because clearly these questions are important to the viability of their staff, very important to the viability of their customer base. And I'm not asking for any particular airline, but the industry itself is making investments, correct? They are making those investments?
We did our study, we were funded from 2011 to 2014. And we got a lot of money from the Boeing company. We got assistance, but no money from Delta Airlines. We continued to talk after our funding ended with Dr. Norris, who was the chief physician. She was thinking along the same lines about what about long haul flights, et cetera. She was interested in studying long haul flights, for instance, to China or to Japan. But money was never forthcoming for reasons that I could only speculate on.
Absolutely.
This is Byron Jones again. My experience is similar. We have received substantial funding from Boeing over the years. The airlines, I think they see themselves more as implementers as opposed to the people who generate the information that's needed. That's just my opinion.
And this is Heather. I would just add that my understanding is Boeing has talked about starting up some research, but I haven't seen any estimate of other investments made on research for private sector yet.
Absolutely. Well, in my final moments, I'll just simply note the world has changed. It's never going to be the same. And as we had our hearing earlier this year in committee with 1 million plus other pathogens lurking out there in the environment, what we do now is just necessity for the rest of humanity's time on this planet. And with that, I yield back, Madam Chair. Thank you very much.
Thank you very much, Mr. Lucas. The chair now recognizes Ms. Lofgren for 5 minutes of questions.
Thank you so much, Madam Chairwoman. It strikes me that we are very unprepared for this pandemic in terms of air travel and all public transit. That we need to have some standards that are science-based, and that probably we're going to have a regulatory role in order to make that happen, because the private sector has simply not done it. They haven't done the research, and even things I understand that just changing where the airflow comes, whether it's from the bottom or the top, would have an impact in terms of dispersal of aerosols, and yet that hasn't been done. When I look at not only in the aircraft themselves, but in the airports, it's very inconsistent airport to airport, where clearly disease is being transmitted. We know that for a fact. Here in California, LAX had a huge incident at the very beginning of the pandemic. So, Dr. Krause, it seems to me that we ought to vest the research. There ought to be some public research, because the airlines are going down. I mean, they're going down financially. And your description of somebody going to the restroom, coughing, touching all the seats, I mean, that's a reason why nobody wants to get on an airplane today. So do you think that the university community, with some basic research funding, could quickly come up with implementation recommendations based on science to get at least a standard in place promptly before all the airlines go completely under?
This is Heather. Dr. Hertzberg might be able to add some more. I would just offer that, there is a role for federal research in this area in terms of understanding the risk and transmissions, also to develop mitigation strategies and kind of test technologies. So I'd offer that there is a federal role to evaluate different options and to reduce the risk. Dr. Hertzberg might be able to speak a little bit more to the university's role. I know that in our work that we've done in FA R&D, we have found that there can be some opportunities for FA to partner with the private sector to accelerate some research and do that. So that might be something to look into in terms of the federal.
Well, maybe Dr. Hertzberg could comment on that then.
I think that universities are full of very bright people, and that they could, with the appropriate funding, come up with some answers. In terms of the science itself, science takes time.
Yeah.
And so it might be quickly in the time frame of science.
Right.
That could be 2 or 3 years.
Well, when I look at, for example, looking not just at the aircraft, but the airports, if you go to foreign airports, there are measures in place to detect people with temperatures, for example. We don't have that anywhere. We could do an assessment. We don't have to do all the research ourselves. Is that effective in the airports that use it? Is it something that we ought to implement? It doesn't look like anybody's in charge of doing these assessments.
It's not a straightforward answer because people can be asymptomatic
Sure.
and have the virus and shed it and transmit it that way. So just taking temperatures alone is no guarantee.
My time's expired, Madam Chair. Thank you so much. I yield back.
Thank you very much, Ms. Lofgren. The chair recognizes Mr. Posey.
Thank you very much, Madam Chair. This is from Ms. Krause, based on her expertise and reading her testimony. You mentioned that there are a variety of technologies that could help address infectious disease transmission associated with air travel, but they're at various stages of maturity. These technologies will help much needed consumer confidence that will lead to an increased air travel, obviously. This is already being reflected with the travel data from the TSA. According to the TSA, checkpoint travel numbers for 2020 and 2019, the U.S. had its highest traveler throughput of 590,456 passengers this past Sunday. That's the highest since the start of the pandemic. Some of the technologies that you mentioned include handheld infrared thermometers by TSA agents, mass screening of crowds using thermal cameras, and aircraft disinfection methods using heat, chemicals, and UV light. How promising do these screenings and disinfection methods appear to be to you at this point?
I think that's still to be determined, but that again could be a role in terms of leveraging research that's already out there and have been done even by some of the research of the folks on the panel, and looking for federal leadership and understanding sort of options and identifying options and how to make it safer. So I would say there's some more work to be done to understand what works to mitigate the risks.
The other area of concern is that if you could have an airplane that's clean as a whistle, but you have one infectious person on there, and you put a lot more people at risk.
Are there other technologies in the works that you think look promising?
Not that I'm acquainted with, other than just doing rapid PCR swabbing and doing rapid PCR on everybody.
Ms. Krause?
At this time, no. I think it is. There's a number of ideas that are being floated out there and a number of actions that the airlines are taking, different disinfectant technologies. I think, again, it's all sort of research that needs to be further developed to understand what might best mitigate some of these risks.
You mentioned that NASA, along with the FAA, in your testimony on how it is responsible for management of the federal government's civil aviation research and development. How has NASA helped with identifying these technologies and solutions?
At this point, it's not something we've looked into, but we'd be happy to work with you to get a better sense of that.
Yeah, with NASA's expertise on spacecraft air quality issues, and they are working with the CDC and other federal agencies, it seems like it would just really be a great synergy to bring them together.
Yeah, I think it is. You're right. I think it's important that the aviation, the different federal aviation industry or agencies come together, as well as public health, that it really is going to need multiple federal agencies to coordinate and come up with solutions.
And who do you see as being the lead agency to kind of get this moving and get it coordinated?
I mean, I think at this point, FAA and DOT have largely deferred to CDC when it comes to passenger health issues. Again, they're looking to take some different steps to establish some guidelines, but largely they've been leaving the research. We do think that FAA has a role in understanding how this research, what's out there, and being aware of the research and figuring out how to apply it on aircraft, that there is a role for FAA there.
Thank you. I see my time is about to expire. I yield back, Madam Chair. Thank you.
Thank you, Mr. Posey. Mr. Barra, you're recognized.
Yes, thank you. This obviously quite interesting, I think, to many of us in Congress, because a lot of us are going to get on an airplane today or tomorrow to fly back to Washington, D.C. And obviously, as a physician, I think a lot of us, rightfully should be concerned about our own health, because we're all coming from 435 districts all around the country, and then we're all going to fly back to our districts, and it is certainly of concern. Just thinking about it from a healthcare perspective, we know a lot more about this virus than we did previously, right? We know that transmission is certainly a component of exposure to virus load, as well as a function of time as well. And, so it does give us some cause for concern. If you're on for me, coming in from California, I'm going to be on long flights with folks. There are things that we can do to certainly mitigate things. Certainly the science is pretty strong on face coverings, face masks, reducing the spread if I'm infected, to infecting others. We're still learning a lot about fomites and the transmissibility off of inanimate objects, solid surfaces, and we know different surfaces the virus survives for a longer period of time. Dr. Hertzberg, your example of touching the seats, we do know constant hand washing and constant use of hand sanitizer, as we certainly will reduce the spread of virus to ourselves. I guess a question for any of the panelists, there is some suggestion that for those that are traveling more frequently, like members of Congress, instead of just wearing the usual face covering or face mask, that it may be appropriate for us to wear N95 masks now that there's a better supply. And I'd just be curious if any of the panelists have a thought on that, whether we should suggest that members of Congress actually get one N95 mask that they can use on those travels, or if we suggest that to the passengers. If any of the maybe Dr. Hertzberg.
N95s need to be fit tested, and so they should not be worn just buying one off of Amazon and putting it on. Having said that, masks work in two ways. So they with an N95, you're filtering out particles that you're breathing in. But even, surgical masks or cloth masks, they prevent you from transmitting the large droplets even as you're talking. And so I think that masks in general are a great idea.
So we
the N95 that I'm wearing protects me, right, but it also protects you. The cloth mask I'm wearing doesn't protect me, but it protects you.
Right. And, again, this may have been touched on earlier, but it's my understanding that over recent years, the airlines have improved their ventilation systems and the filters in those ventilation systems. Is that correct? Any other panelists?
This is Byron Jones. The almost universally, the recirculation air in the aircraft is HEPA filtered. So you're not spreading disease around through the aircraft by the recirculation of the air. The basic functioning of the environmental control system is pretty much the same as it's been for the last 20 years or so. And the regulations on that haven't changed dramatically in recent times. And the thing to keep in mind is the aircraft are in service for a long time. So even if you start changing the way they're made now, for example, that Boeing 787 has a different system, but you're still going to have aircraft in service for many years.
Right. And just a quick last question for Ms. Krause. Most airlines, if not all airlines, are now mandating the wearing of face coverings. Is that correct?
Yes, that's what's been reported. I know that the airlines associated with the A4A in particular are working to use or have masks as part of their policies.
Great. And it looks like I'm out of time, so I'll yield back.
Thank you, Mr. Barra. Mr. Byer, you're recognized.
Thank you, Madam Chair. I had to find my unmute button. And thanks so much for holding this hearing. It's really interesting. One of the major issues I was concerned with at the start of the pandemic was the inability of the airlines to effectively contact trace passengers. And I learned that the US government had been pressuring airlines for years to collect contact information for passengers just in the case of this kind of contagious virus. And yet the airlines allegedly repeatedly refused. So we're just now coordinating a digital app to do this across the industry. But as the coronavirus spread across the United States, public health officials were not able to effectively contact trace. So a question, Ms. Krause, in the 2015 GAO study that you referred to a number of times, you found that DOT would be the most effective at organizing a national aviation preparedness strategy. First question is, why no progress? I saw the pushback that they thought maybe HHS or DHS would be better, but we're now 5 years later with a strong GAO study that says they should have been putting together an aviation preparedness plan.
I think you hit on the reason why it is we haven't seen implementation or movement on it is because DOT doesn't believe that they should be taking the lead. They see HHS and DHS being the ones that should lead it based on their public health and emergency preparedness responsibilities. They do point to some of the actions they've taken as it relates to COVID, things where they've facilitated calls with aviation stakeholders, airlines, and federal agencies, coordinating with CDC on guidance for airline crew, but they don't see it as something that they should be taking the lead. We reiterate that we feel it's important for them to take the lead and that they should be taking the lead given their long-standing relationships and deep ties to the aviation industry as well as their oversight responsibilities. So we are looking for them to take the lead on it.
It certainly makes sense. I'm always fascinated because you don't usually see people say, oh, I don't want responsibility for that. Most of us are empire builders. We pull things into ourselves. And certainly having them take the lead doesn't mean that you exclude HHS or DHS from the conversation or the construction.
Absolutely. I think that's what makes it really important. I mean, there really is a need for a multi-agency coordination effort when it comes to responding to communicable disease threats. I mean, you really want to have that coordination so you avoid confusion, inconsistencies, duplication of resources, and really minimize the inconveniences to passengers. So it's important that there is coordination across these agencies to respond.
And Ms. Krause, don't we have a constructive international obligation based on the Chicago Convention, the Annex 19 that you mentioned?
Yes, so that as a signatory to that International Aviation Treaty, the U.S. is obligated to create such a plan.
If I ever get a chance to meet the chair of the Space Subcommittee, I'm going to recommend to her that we have Science Committee legislation that mandates that DOT do this National Aviation Plan. Not just a GAO recommendation, but a mandate from Congress.
And that, I would just add, that is something that GAO is looking to elevate to a potential matter to Congress, is to look to Congress to direct DOT to implement this plan, because we think it is very important.
This hearing has been worthwhile in many ways, but especially what you've just presented. So, follow-up question too. I opened saying we couldn't contact trace airline passengers. Wouldn't that have been much easier if we'd had this plan in place?
Yeah, I think that we definitely see that the plan would have provided some opportunity to outline some of the coordination and roles and responsibility, as well as communication mechanisms. When you have a preparedness plan, one aspect of it that could be a benefit is testing out some of those communication mechanisms, as well as identifying the roles and responsibilities. So when you get into situations where you need to quickly respond, you have some agreement on who's doing what.
That's great. Thank you very much, Ms. Krause. Dr. Jones, I'm almost out of time, but your notion of showing up 4 hours ahead of time may become more plausible as we develop tests in the near term that will give us a result in 30 minutes or less, where you can do it with saliva or with blood. And I hear those are coming in the coming weeks. And with that, Madam Chair, I yield back.
Thank you very much, Mr. Byron. Ms. Wexton, you're recognized for 5 minutes of questions.
Thank you, Madam Chairwoman, and thank you to the witnesses for being with us today. I appreciate my colleague from Northern Virginia anticipating some of my questions actually about preparedness and DOT's reluctance to get involved in developing these plans, because as luck would have it, now I represent Dulles International Airport in my district, Virginia 10 here in Northern Virginia. And as luck would have it, I had a Zoom call with a number of representatives of various worker groups at Dulles Airport yesterday, and they all were expressing concern about DOT's reluctance or inability or unwillingness to engage in this kind of comprehensive planning for aviation industry. So I'm glad that we're looking at ways to require them to do that and to mandate them to do that. But unless and until that happens, we need to look at what the other options are. And I'm very proud of Dulles Airport because they're one of 14 airports reviewed by GAO in 2015 when they looked at the preparedness of the U.S. aviation system in responding to Ebola and to communicable disease threats from abroad. And Dulles had independently developed a preparedness plan of their own, despite not being required to by U.S. law. Ms. Krause, can you discuss what goes into an airport developing a plan like that, a preparedness plan, and how heavy of a lift is it?
I mean, what we found is when we looked at the 14 airports, including Dulles, is we assessed it against sort of high-level components that were out, or many of them had the high-level components that would be outlined in federal guidance and international guidance related to preparedness. I think that we found that the plans had varying levels of detail, but that they were good, that they had good elements in them. I think the big piece of it is that their FAA has often said that some of those individual airport plans are focused on situations where you're dealing with one or two flights, with infected passengers, and it doesn't sort of support that national level response. So I think that's where we feel like the National Aviation Preparedness Plan would really help kind of take those various efforts from the different airports and even airlines that also put together plans and sort of get them working harmonized and in support of a national response.
So it's safe to say that there are differences between the plans that the airports have, right? I mean, those that even have them or had them going into this pandemic. But absent a national preparedness plan, how can we ensure that there will be adequate health and safety standards across all airports as they develop plans related to COVID-19?
I think that's really where a plan comes in, is sort of identifying what are the things that you're looking to coordinate and communicate on at a national level. And then that can help the individual airports and airlines really align their plans to those efforts.
Well, I hope that we come up with a national strategy because airports shouldn't have to, and they shouldn't have to reinvent the wheel every single local airport. So, well, thank you very much. I will yield back with that.
Thank you, Ms. Wexton. And now recognize our honorary subcommittee member and full committee member, Mr. Weber, for 5 minutes.
Thank you, Madam Chair. This is a great hearing, by the way. What a great hearing. Dr. Jones, I want to go to you at first, if I can. You said you're a mechanical engineer by trade, and I was an air conditioning contractor for 35 years. Do you know of any studies or any information about relative humidity in air cabins? In other words, the heavier the air, the more humidity, does it affect those kinds of, we call it particulate matter droplets? Do you know, does it affect that?
It definitely has some effect on it. Two things. One is obviously the low relative humidity, which is typical in the aircraft cabin, makes the droplets evaporate more quickly. So that means they become smaller. The viral material and other materials that's non-liquid, non-water based in them will not evaporate, so that material stays. So the smaller they are, the more easily they are to move about the cabin. The other thing is that humidity has a pretty significant impact on the viability of the viruses, and they become inactive much more quickly in a moderate humidity range. But on the flip side of that is that the air turnover is so fast in the aircraft that we haven't seen much evidence that there's loss of viability once they're airborne.
Well, thank you for that. I want to open up the question for the panel. We've talked about SARS, Ebola. I didn't hear H1N1 in there. But was there tracing that went on back during those epidemics, whatever you want to call them? Was there tracing back then? Dr. Hertzberg, start with you maybe.
Yes, there was. There have been publications where they have attempted to contact passengers. We used a study of an influenza infection on an aircraft that was set on a tarmac, and the air system was turned off, and it sat on that tarmac for 3 hours or something like that. And out of the passengers, like 75% of them became later infected with influenza. This was back in the 70s. There have been other reports of H1N1 being transmitted on aircraft, and those have been traced. The classic study is one of SARS that was reported in the New England Journal of Medicine, a 3-hour flight from Hong Kong to Beijing. And again, they did contact tracing for those individuals. Of course, that's China, so it's a little bit different.
How about you, Ms. Krause? Would you like to weigh in on that?
Contact tracing is an area that we're looking into a little bit more to understand some of the challenges around developing that kind of a system when it comes to the aviation system. I mean, I think there are requirements for pilots if they're seeing infected passengers to report it. So there is multiple agencies involved when you're dealing with tracing and understanding contact.
Okay. And Dr. Hertzberg, I'm going to come back to you. You talked earlier about being in contact with Boeing. And of course, Boeing is obviously the largest airplane manufacturer in this country, I'm sure. But there's other airplane manufacturers, especially Airbus over in France, for example. Any input from any of those other manufacturers?
No.
Not at all.
No.
Have we reached out to them?
Not to my understanding.
Okay.
I'm just a little old faculty member here, doing my job.
Well, thank you for that. And then the last thing I want to say is I like Bill Posey's line of questioning about NASA. Obviously, NASA is very, very good at quarantining and for a lot of reasons, but any plans that anybody knows of to actually get NASA, maybe Chairwoman Horn might want to get some NASA people in here and talk to us, but has anybody had, any of our panelists witnesses had conversation with NASA directly about that? No? Mr. Jones, Dr. Jones?
No.
And I guess Ms. Krause, no?
No, but I mean, I think that's to leverage whatever federal knowledge and research is out there is important.
Yeah, well, I appreciate that. All right. Thank you, Madam Chairwoman, for letting me ride on your coattails. I yield back.
Well, thank you very much, Mr. Weber. It's always a pleasure to have you with us on this subcommittee. And we've gone through all of the members that are with us. Oh, wait, I stand corrected. I think we have one that has returned. Mr. Lipinski, are you here? Mr. Lipinski.
I was just put in. Thank you very much, Madam Chair, for letting me join the subcommittee here today for this hearing. It's something that is critically important right now for us as the chairwoman of the full committee, Bernice Johnson, mentioned, for all of us as we travel a lot back and forth to DC and to other places. So the safety of air travel is really important. And like Ms. Johnson, I'm also on the Transportation Infrastructure Committee. And so this is something that we have been going back and forth with the FAA on, in terms of the FAA putting requirements on for air travel, which has not really been, FAA has not stepped up in that. Airlines have done some of that voluntarily. But I wanted to ask on the research side here today, I want to ask Ms. Krause, do you believe that FAA and NIH are adequately coordinating on the research problems that we are discussing here today?
At this point, I mean, we've only had some really initial conversations on that topic. I'm aware of informal coordination that's happening, but not a formal coordination that's happening on this topic.
And how do you think that Congress could better facilitate this coordination?
I think asking the question is important, and sort of encouraging that coordination occur. I mean, I think I would that really leveraging all the knowledge that these different agencies have, and it's important in this particular instance to have public health as well as aviation sector coordinating in terms of figuring out the risks associated and sort of what mitigation can occur for aviation travel.
I want to ask all the panelists, are there ways the federal government can incentivize additional public-private partnerships in research efforts about cabin safety?
I mean, I can start. So I can start with some perspectives. I mean, I think when we have looked at FAA's R&D, they do have a number of mechanisms that they can use and that they do use to coordinate with the private sector on addressing R&D issues. It can also provide them an opportunity to collaboratively work with industry and in the private sector in accelerating needed research. So there are some opportunities there.
Speaking from a researcher point of view, money always talks. And, if there's the money there, the research will be done.
From my experience, especially with the federal agencies, when there are specific calls put out, that usually gets a good response to that. It takes a scientist a long time to prepare a proposal for something that's unsolicited. So I could write a proposal to the NIH or to the NSF, and it would take me hundreds of hours to do that. And based upon my discussions with the CDC, when we were at the end of our Fly Healthy study and trying to kind of drum up more business, they were very unenthusiastic. I could not imagine that we could have gotten similar enthusiasm from NIH or NSF. And therefore, in my own little cost-benefit analysis, I decided it was not going to pay off to submit such a proposal at that time. I might do it again. I might do it differently today.
Thank you. And in the little time I have left, Dr. Hertzberg, on a different different subject here in terms of not in the cabin, but the safety of ground crew. I have Midway Airport in Chicago in my district, and a lot of airport workers are in my district, from bag handlers to maintenance techs. So Dr. Hertzberg, do you have any thoughts on how airport ground crew can best protect themselves, be protected as travelers may be exposed, pass through their workplace? So what can we do for the ground crew in terms of safety?
They should be observing physical distancing. They should be wearing masks. They should be staying well hydrated. They should be constantly washing their hands and keeping their hands away from their face.
Thank you. And I want to thank all of the witnesses for their testimony today, especially Dr. Jones as a fellow mechanical engineer. I especially appreciate your work. But thank you all of our witnesses, and I thank the chairwoman for allowing me to join with the subcommittee today. Thank you. I yield back.
Thank you very much, Mr. Lipinski. And before we bring this hearing to a close, I want to echo my gratitude to our witnesses and all of the members for this incredibly insightful and important hearing. I think that we have touched on and are just beginning a play in this critical place and needed action. And Mr. Byer, yes, I agree. We should take some action, and I think more needs to be done. We've raised important issues, and I'm coming away with a few takeaways that just to echo Mr. Lucas, that these threats will continue. There are millions and billions of potential threats to our health and safety, and from our witnesses that we simply don't know enough right now about how to mitigate and the spread in a quantitative way. Dr. Jones, that we don't have a plan and that we don't have clear responsibilities, that more research is needed. Interagency coordination is absolutely required, that the need is incredibly urgent, and that Congress needs to act. Now, there are a number of ways that we can direct this research and move forward, but the timeliness and the criticality of addressing these issues seems to me very present. So I appreciate everyone and look forward to working with my fellow committee members on this issue to take action to address this and find a way forward to incentivize research, R&D to keep it going, and then make sure that there is a plan to increase public safety. And thank you again to all of our witnesses here today. The record will remain open for 2 weeks for additional statements from members and for any additional questions the committee may ask of the witnesses. Thank you again for your participation, everyone, today. The witnesses are excused, and we are now adjourned.